As Paul said, my name's Georgia, and I spent nearly 2 years working with Sheffield CCG on our Transformational Survivorship project here in Sheffield. We started that phase 2 of our project back in January 2013 with a really simple premise, and that really is given away by the sort of title of our project, that this was about transformation. It wasn't about us necessarily doing more, but it was about us trying to do things differently. And there lies the challenge, of course, because that is where all this huge cultural change kind of comes into play. From the Commissioner perspective, I would say there was a little bit of a subtext to that, which was try not to spend too much money. So we absolutely were trying with our project in Sheffield to look at our existing resources in the city, how we could tap into those resources across all of the sectors to bring about improvement and change and ultimately enhance the experience and outcomes of people affected by cancer in Sheffield. As you've already heard, there were a number of drivers as we started our Phase 2 project in 2013. So we had a very strong user voice. The voice of people affected by cancer absolutely ran through the whole of the work that we did. And I know you're going to hear about the Doncaster work shortly, which really does demonstrate a very clear co-production approach. But we really wanted to utilise the learning that had come out of the national work that had been influenced by that patient voice. We also had very clear involvement in users in our project in Sheffield, not least of which we were able to tap into a fantastic survivorship focus group that was being led by our Cancer Information and Support Centre to make sure that as we developed our work, it was always guided and shaped by our patient and carer voice. We, of course, had our national and local learning, which I'll just mention a little bit more in a moment. And the other big driver for us at this point in Sheffield was across our cancer network. We'd had a number of clinical follow-up pathways that had been revised and changed. And that brought with it very specific sort of focus around certain pathways. And for us in Sheffield, over the last couple of years, our work has particularly focused around colorectal cancer. As already been said, we started Phase 2 at a point of time where there'd been 5 years of learning from the National Cancer Survivorship Initiative, not least of which was the recommendation that was in the Improving Outcomes strategy that was published in March 2013 around the benefit of the recovery package. And we were very clear at that point as we were trying to kind of develop our project brief that we were going to utilise this learning and make sure that we applied it in what we were doing in Sheffield. In terms of the colorectal pathway, I'm afraid this is a very busy slide, but essentially the changes that had occurred had been about reducing the reliance on secondary acute care in terms of delivering the follow-up pathway and trying to move away from that kind of one-size-fits-all approach to become much more tailor-made, more risk-stratified, more about the patient need. But as we sort of started that second phase, as I say, back at the beginning of 2013, we'd already implemented this pathway in the acute trust. But when we sort of looked at actually, how was this going to work in reality for patients as they made that transition away from their hospital team, it became very apparent that there were huge gaps that we really needed to fill. So we kind of looked at that clinical pathway as being the bare bones, really, and we needed to put the survivorship meat on those bones, the survivorship framework, and that was very much, as I say, about the emphasis of the recovery package. We also had the learning that had come out from the very key work that Macmillan had done with Monitor around routes from diagnosis, which had really told us a lot about the patient journey and about the different cohorts and the needs of those different cohorts of patients as they go along their pathway. But what we felt at this point, and this was really the voice of not only our patients, but our acute secondary care clinicians and also our primary care colleagues, is that they didn't feel the confidence that we could fully apply, that we tried to embed and build that structure and framework first before we sort of moved into trying to implement much more revised risk-stratified pathways. So we ended up with a number of work streams, and to be quite honest, I was new in the role as a project manager, and I think we were probably a little bit ambitious. We had 18 months, and we really sort of set off with this aspiration to try and fix a bit of everything that we could. But I actually think, and I'm glad to hear that Dr. Stein sort of recognised that we're very enthusiastic here in Yorkshire. that there's no harm in having that ambition, that we knew that there were so many areas where we did need to start to make a difference. So, of course, we had a very key focus around the recovery package. We also knew, however, that we needed to do work out in primary care to ready them to receive those patients on those new clinical pathways. We knew that we had to do an awful lot of work in terms of upskilling and raising confidence around the different stakeholders and groups of people that would be supporting cancer survivors in the future. And we really wanted to have a very sort of clear focus around rehabilitation. So we've done some work with some of our local partner organisations, particularly around employment, improving access to specialist employment help for our cancer survivors. And we also sort of started to dip our toe a little bit in trying to develop a physical activity pathway, but I'm very glad to say that was passed over into the hands of a very capable team at the Hallam University, and I know Lindsay's going to be talking to you about that shortly. Once we'd kind of decided what we were going to do, of course we needed to put together our task group, and I apologise, because having seen Ali's really rather professional slide about all the stakeholders, this was what I'd put together for a previous presentation. And I must also apologise that the IT crowd bit, because this was specifically related to how we developed our treatment summary work, but really that could relate to any number of stakeholders across a number of health and wellbeing sectors, including our third voluntary sector. But as we all know in this room, for any of this work to actually come to fruition, for any of it to be meaningful, you've got to have engagement from all the right people. And of course, at the heart of it is your patient, your user voice, but you need your clinicians, you need your varied expertise, and you also need a bit of muscle from your management, and that's really important. So in this context, in our acute setting, we needed that managerial buy-in to recognise that this was an important issue, and actually they needed to invest some time and changes at the beginning of the pathway to make it successful. And then, of course, we need our commissioners to buy in too. So just to kind of touch briefly on some of the work that we've done around the recovery package. As has already been said, and I think Ali very poignantly said, don't assume that we know what cancer survivors need. And I think as health professionals, we've always had that tendency to make that assumption, to think that, with our experience, we kind of know what the problems are going to end up like. And therefore, we've kind of dictated the care and support that we've given to people without really giving them the opportunity to define those problems for themselves. The colorectal cancer team at Sheffield had already introduced holistic needs assessment into their pathway back in 2011 when the cancer pathway was changed. But I think what we'd learned over that 2 years, and I used to work with that team, so I had the benefit of kind of knowing what had been going on for a number of years, is that we weren't really using that holistic needs assessment in an appropriate and meaningful way. We weren't really using it to shape the future support that we were giving to our patients. And again, quite significantly, and been said a number of times, we weren't sharing that information with anybody. We knew, but we weren't passing that on to anybody else. So the work that we've been doing with the clinical team has been more about looking at that process, how we should revise that in terms of making it more meaningful from the patient's perspective, but also how we then pass that information on to the next person and how that information informs the care plan. And as Dr. Stein already said, that care plan being a fluid thing that everybody contributes to. It's not just a static document that gets filled in once. We also have done quite a bit of work out in primary care around improving the cancer care review. Cancer care review is part of the quality outcomes frameworks for our GP colleagues. But we know, and the national evidence supports this, that the delivery of that had been fairly variable. And certainly when we started to talk to the wider group of our primary care colleagues in Sheffield, it became apparent that there was some inconsistency to how that was delivered. And it was often a bit opportunistic, patients would just be there in practice for another reason, and they kind of had a very quick cancer care review, are you okay, box ticked. And of course we wanted to make that a lot more meaningful and actually a more valued and recognised part of that integrated pathway. So we had a number of approaches. First of all, we developed and ran a pilot where one of our project team actually went out and worked directly with practices just to really try and bring about some increase in knowledge and awareness, to promote some of the additional resources that we'd also developed, but also to kind of explore a bit further the role of nurses in terms of kind of performing cancer care reviews. And that was very much thinking along the lines of our practice nurses already doing long-term conditions reviews and having, you know, a wealth of skill and ability that would be very easy to sort of transfer over with some additional support into cancer. And I think of all the things that we've done in Sheffield, that's been one of our most successful elements, and I'm really pleased to say that Louise, who's in the audience, is now got a substantive post with the CCG to take forward the cancer work in Sheffield and continue to work with practices. We also recognised that we couldn't just expect our primary care colleagues to suddenly become experts about cancer, and I think we've already heard that. You know, they're generalists and they have knowledge, but, you know, we have to support them to make sure that they have resources that will give them a bit more confidence and ability in supporting people in a different way. So again, we took some of the work that had been done nationally. We developed a cancer care review template for System 1, which was the GP IT system that was predominantly used in Sheffield. And that template was based on the national work that had been done, but also had a lot of involvement from the clinical teams and review from our users. And that was all about really trying to give a bit more of an aid memoir, a bit more of a prompt around the cancer care review. So even if you were somebody undertaking it for the first time as a practice nurse, there was a bit more of some guidance around it. And it's not the be-all and end-all, but we were trying to put some resource that would give people a little bit more confidence to undertake that change in the review. And we linked that to obviously the newly developed kind of care plan. So there was prompts on there to review the care plan, so that we were kind of nudging the sort of the thought that needed to be something that continued to be reviewed and updated. And we developed an electronic resource as well that in one electronic place gave GPs and practice nurses and other professionals access to the resources that were available in Sheffield to support cancer patients, and we mapped those against holistic domains, and we used a piece of work that had been done in phase 1 of the Survivorship programme to develop that. We also ran 2 different types of health and wellbeing programme. So we worked closely with our local Cancer Information and Support Centre, who those of you from Sheffield will know, absolutely brilliant resource for us here in the city, and who already had really great experience in sort of supported self-management programmes. And we developed with them a programme called CALM, which was Cancer Attitude and Lifestyle Management. And this was a programme of health and wellbeing to sort of promote self-management, improve confidence, improve self-esteem in people living beyond cancer. The CALM programme was ran several times over the course of the project, and what we actually found was, although people that attended could see there was benefit, at the end of it, actually it wasn't quite right for our cohort of patients. And I think that's always important to learn, that sometimes not everything is going to work for every type of patient, as we've already heard. But it's good to have those options available. What was in some ways a bit more successful was a roadshow event that was held in this very room, in actual fact, where we had invited a load of resources, different resources, support resources across all the sort of partner organisations to come and be in this room, and patients and carers were invited to kind of come along and get a feel for what resources were out there in the city. In addition to which, they were able to kind of have taster sessions around complementary therapies, they were able to do taster sessions around physical activity, they could talk to the dietitian, we had physios, all sorts of people in the room. And what we got in terms of feedback from that event was very, very positive. And some of those people were very early in their pathway, and some of them were several years down the line, but really appreciated that reminder of what was out there and the things that they could access for support. And again, in terms of taking that forward, the CCG are very keen in Sheffield to continue to deliver that kind of event, but again with much more of a kind of long-term conditions focus, so cancer will come within that. Probably our biggest headache has been in the development of the treatment summary, because despite the national work and despite the fact that there was a template sitting on an electronic system that we used in Sheffield, it was actually extremely hard to get this to the point of delivery. And I think over the last 18 months, we've probably given more time to treatment summaries than any other thing. But really, I think we do recognise the absolute value of passing on crucial information diagnosis and their treatment, but it also includes information about the outcomes of holistic needs assessment. It tells the GP and primary care clinicians exactly what we need of them in terms of surveillance and clinical review. And also, importantly, it gives information for both those clinicians, but for the patients around signs and symptoms of recurrence, and also around the potential late effects, so that down the line, if those patients are going back to their GP with problems, there's at least a reference point to be able to say, well, this might be related to that previous treatment. As I say, getting the treatment summary to the point of actually delivering them was extremely hard, and the main problem that we had, and it's good to hear that America's no better really, is that our IT systems just didn't talk to each other. So we couldn't pull information from all our different clinical systems in the hospital to populate this. So we actually needed to do quite a lot of legwork to get to the point that we could produce a treatment summary in a sort of quick and effective way that wasn't going to be really time consuming for our clinical colleagues. And we've been very lucky in Sheffield that we have nurse-led follow-up, and we have done for a very long time in the acute trust in colorectal cancer. So we were able to engage those nurses who are all in the room to sort of take some ownership around the treatment summary. And we specifically focused on generating this at the point where patients were transitioning back to primary care for the first time. So really, just to summarise it, in terms of the Sheffield work, there are a number of other things that we did, but predominantly what we tried to do was we look at our revised follow-up pathways, and we looked at what we needed to focus on to sort of support that and make this fit. So that was holistic needs assessment, that was about the work that we were doing out in primary care, and it was about improving communication. And I'd just like to say, just as a warning shot, and I trawled for hours to find this picture because I thought I needed something that most resembled me, obviously. Thanks. It's not easy, and I think all of us in this room who have been involved in survivorship work know that. Anybody that works in the NHS these days knows that it's not easy to bring about change. And even just implementing the recovery package, we've really only just scratched the surface here in Sheffield. I think we've done some good work and we're proud of our work, but we've got, lots to develop, lots to embed, lots to roll out, particularly across, other tumour groups. But I think we've at least started to lay a bit of a foundation so that as we move into the next phase of our survivorship work in Sheffield, we've got some blocks to build on. I'm going to pass you over to Liz Cooper now, who's one of our matron practitioners in the colorectal team at the Northern General here in Sheffield, who's going to talk to you a little bit about the reality of the other side of this work. So thank you.